introduce our presenter, Sandra Smeal, who is the coordinator of expertise in inclusive aging, diversity, health, and well-being at the Centre de Recherche et d'Expertise en Gerontologie Sociale. Smeal's work promotes the inclusion, health, and wellness of older adults by attending to intersectional issues in long-term care. Her current focus is building creative community relationships and promoting practices that support wellness in residential homes. Thank you, Sandra. Welcome.
Thank you. Thank you for this opportunity to be part of this event today, and to the other presenters and everyone here. I really appreciate this opportunity. I'm going to see if I have any technical issues here and for sharing my screen. Let's see, did that work for everyone?
Yeah.
Is it full screen or am
No, not yet. If you could make it full screen, that'd be great.
Okay, is it all right? For some reason it's on my other screen though. Okay, I might be looking sideways as I'm presenting. I apologize.
That's
all right, so once again, I'm Sandra Smeal with this ridiculously long title. Usually I would just say I'm a coordinator, IDSB, Inclusive Aging, Diversity, Health and Wellbeing. And as Kat mentioned, I'm at CREGÉS, which is the Center for Research and Expertise on Social Gerontology, located in Montreal at the CEUS Centre-Ouest. So that's the Health and Social Service Network in West Central Montreal. And at this research center, we focus obviously our work on social gerontology, so we attend to aging as a social process, most fundamentally as a social process, not simply or most fundamentally a biological process. And my role there, as Kat mentioned, is really to support the development of research collaborations that contribute to the development of health and social care practices that support the health and well-being of older adults in all of their diversity, so including their sexual and gender diversity. And my presentation today actually builds on the work of some of my colleagues there, Maud Lecomte and Joe Ducharme, and the work that they have been doing to develop trainings for the health network. Unfortunately, these trainings are not mandatory. So, you know, just referring back to the previous presentation, they need to be made mandatory, but they're not at the present moment. They're also not available in English, unfortunately, which is another issue. But the one set of trainings is available not only to the Health and Social Service Network, actually it's now been made available to the community. That's the first set of trainings that's really more oriented towards safe and inclusive health and social care more broadly. And then we're coming up with a new training on a new set of trainings on dementia care and end of life and palliative care for gender and sexually diverse older adults that will be coming out soon. We're still finishing that training. So I will go to the next slide. So I've got just 4 components to this presentation today. I'm going to be taking up the need, unfortunately, the continued need for safe and inclusive health and social care. I'm going to be taking up intersections with dementia, so attending to needs that are that exist in relation to dementia care and promising practices relative to that, and then needs in relation to palliative and end-of-life care, promising practices in relation to that, and then conclude with a call to action and some other areas that I'm not taking up in this presentation, but that came up through the review of the literature and the consultations that were done through CREGÉS. So just a brief note on the material that's been used to put together this presentation. At CREGÉS, we did a consultation with older adults who belong to gender and sexually diverse communities. We also consulted members of the Health and Social Service Network and organizations, community organizations who provide services. And then we conducted 3 literature reviews were done to identify, you know, what has been written about meeting these different needs to help us identify the promising practices as well. And we also conducted a number of consultations with different experts in terms of the materials that were developed. So just in terms of accessing or the need to access safe and inclusive health and social services or care rather, obviously this is something that we know exists, and given the growth of the older population, you know, there are more people with these needs. These needs existed prior to the population aging, but this, you know, there are more people who have these needs now. So in that sense, there might be more, we could say that there's a more pressing need to address these needs, but it's not simply a matter of numbers. You know, these needs previously existed, but there are, what's encouraging in the current moment is that there seems to be some political will to address some of these needs. So there is this an action plan that was released at the provincial level that was against the mistreatment of older adults, and it included a particular measure that actually supported CREGÉS in developing these trainings. So Measure 51 was used in support of us creating these trainings, and there was also the action plan against homophobia and transphobia that included 5 priorities, including you know, promoting openness to sexual diversity, respect the right and support for sexual minorities, the creation of safe and inclusive environments, the adaptation of public services, and the coherence and effectiveness of actions. So there's political will in the province to some extent that needs to be built upon. Then in terms of, so you know, you mentioned the life course approach in the previous presentation, and this also came up in the work that we did, and we looked at the life course in terms of the histories that older adults who belong to gender and sexually diverse communities, those social histories that are part of their experience, right? These are not just historical facts, these are things that events that people have lived through, such as the AIDS crisis, you know, those who have contributed to the rights movements. This is part of their histories, these are part of their life course experiences that need to be thought about, taken into consideration when we're thinking about how to provide care. There are also current myths that continue to exist, forms of discrimination and mistreatment. You know, and those intersect with ageist myths about the sexuality of older adults more broadly. You know, the idea that they don't engage in sexual practices or don't have desires, aren't desirable, that their sexuality and gender are irrelevant as older adults. And then, you know, obviously the other forms of discrimination that the broader LGBTQIA 2S+ communities face, right, in terms of heterosexism, heteronormativity, homophobia, lesbophobia, biphobia, transphobia, cisnormativity, all of those forms of discrimination. And then just in terms of mistreatment, you know, there are also forms of mistreatment that people are currently are subjected to, such as forms of neglect and violence, sometimes non-intentional, but sometimes intentional. They can include the denial of sexual identity and orientation, lack of equitable care relative to cis heterosexual peers, the refusal to provide care. This continues to occur. So these are issues that need to be taken up when we're, you know, obviously need to be addressed when we're thinking about how to ensure that these communities are receiving the health and social care that they deserve to receive. In terms of the promising practices that should be put in place within the provision of care, according to the literature that we reviewed and the consultations that we conducted, there were 4 main components to this. There were attitudes such as, you know, demonstrating openness, being an ally, recognizing diverse family structures. This continues to be an issue. And in terms of attitudes, really there was a recognition that health and social service providers really first need to be able to recognize if they have their own prejudices with regards to gender and sexual diversity. This needs to be a starting point, so they recognize that they have this in the first place. And then there needs to be a movement towards their demonstration of openness and being an ally. I think Dr. Craig mentioned this, that ignoring differences is really problematic. This is not about ignoring differences, it's about accepting and supporting sexual and gender diversity. There's a need for practice of cultural humility with regards to learning how to support each person, because not everybody needs to be supported in the exact same way, and making sure that people are being treated as the experts of their own experience. Obviously, the recognition and normalization of diverse family structures. There are people who have also been treated as objects of curiosity in the context of care, which is something that also needs to be avoided, and not just avoided, but it needs to be stopped, because people are subjects and they need to be treated as people who deserve to have their needs supported. And then there also has to be, in terms of attitudes and practices, the active countering of discriminatory practices, including when the people refuse to provide care. In terms of interactions, informative care is obviously extremely important. Inclusive communication in intake forms, in signage, in bathrooms that demonstrate that there's a recognition of gender and sexual diversity. No one should ever be forced to disclose, obviously, their gender or sexual identity. And then there need to be supports that specifically recognize the impacts of discrimination, including specific outreach to communities. In terms of environments, some of the promising practices included, holding events within, for example, residential care homes. I believe this was also mentioned again in Dr. Craig and Dr. Gua's presentation, holding events that celebrate gender and sexual diversity within these spaces to demonstrate that these are welcoming and inclusive spaces for all people. And this can have an impact on the setting and also those who come to visit the setting. If they don't have inclusive or they had a different they have discriminatory ideas, it might help contribute to changing those. And then just in terms of resources, it's really important that both staff be informed of resources and older adults themselves be informed of the resources that are available to them, and that these resources receive sustained funding. Staff need training, obviously, and as I mentioned, unfortunately, the training that we produce is not mandatory. And then lastly, policies and leadership are really necessary in order to institutionalize safe and inclusive health and social care, because otherwise we're leaving it up to individual staff. And so it's great when staff are trained, but if we don't have policies and leadership in place, it's limited. So that's that for the initial section on just broadly safe and inclusive health and social care for gender and sexually diverse older adults. And then in terms of dementia, the literature demonstrates that there are higher rates of certain risk factors. And again, this came out in Dr. Craig and Dr. Gua's presentation in terms of social isolation is actually a risk factor for developing a dementia. So this is a risk factor it's higher among LGBTQ plus older adults. And discrimination and identity concealment can lead to greater social isolation and loneliness, which, as I said, is linked to increased risk for developing cognitive impairment. Because social isolation can hasten cognitive decline, this can lead to safety deficits and less interaction with the health and social services system, which can lead to later diagnosis and then greater need at the time of service provision when service is actually provided. So this means that in general, the literature is demonstrating, and our consultations also are demonstrating, that these needs are less often met among these communities than the cis heterosexual peers who are living with dementia. And there haven't been any specific strategies that have been put in place despite this need to recognize these dementia care needs for members of these communities. We also found that health and social service professionals generally do not know how to support the needs of older LGBTQ plus adults living with dementia. And overall, they tend to view these identities and these sexual orientations as either secondary or irrelevant when interacting or supporting older adults living with dementia. And this attitude obviously can have an effect of obscuring the needs of these older adults. And in residential settings or in other settings where older adults are living together, this can exacerbate the invisibility of these populations. And then the last point on this slide around ableist or what, I'm sorry, I forget their names and I didn't write them into my presentation. Beryl, Alexandre Beryl and Marjorie Silverman have identified as cognitivist discrimination. That type of discrimination that is tied to the diagnosis with dementia, alongside ageist discrimination, so forms of infantilization and disregard for capacities. So this ableist or cognitivist and ageist discrimination, they're actually quite similar in terms of their manifestation, this infantilization and disregard for capacities. And other forms of marginalization also contribute to further invisibilization of these older adults. And then so in terms of key concerns, there are these multiple forms of marginalization I just mentioned. So in addition to the types of discrimination that all older adults who belong to gender diverse and sexually diverse communities, there are these other forms of marginalization related to cognitivism. There's also in the literature and in the literature that we reviewed, there's a lot of concern around identity and behavior changes that might come with dementia and eventual changes to behavior. And so there's fear that's been expressed of inadvertently sharing gender identity or sexuality with people who they would not normally trust. And there's also fear of forgetting one's identity that's also been expressed. In terms of sexuality and affect, there needs to be space for this, as well as the development of competencies among health and social services personnel, so that supports are provided for the meeting of sexual and affect needs without infantilization and without the assumption of monogamy, of mononormativity. And then in terms of just supports for individuals and their chosen family and caregivers, it's important to note that dementia you can experience even more isolation over time after you have been living with dementia for some time. And so there's a need here to ensure contact with people's support networks, with their chosen family, communication with their family, support for their chosen family. And it's also important to recognize that, and this comes out in the literature as well, that not every older adult who belongs to these broader communities has been actively involved in cultivating ties with them. And so this is in particular, this comes out in relation to trans older persons. Sometimes the transition has occurred earlier in life and they're not necessarily these ties. So this needs to be taken into consideration too, in terms of maintaining ties with communities. Am I doing all right for time? I think I'm still doing all right for time. All right, so then in terms of the promising practices in relation to dementia, it's really important, as I mentioned, to attend to individuals' sexual needs and rights, to recognize that they have these needs and rights as older adults belonging to gender and sexually diverse communities. this comes up over and over and again, the need for recognition and inclusion of chosen families. It's essential in all forms of care, but it's also important in dementia care. There is also in the literature this discussion around clarifying individuals' wishes, ensuring they're respected. And there's a bit of tension in the literature around that because there is a desire to affirm personal identity, but sometimes this can have an ableist type of, it can conflict with a disability positive approach to understanding one's humanity and oneself, as when somebody has a cognitive impairment, they're still fully a person, they still have identity. So there is a bit of tension in the literature around that in terms of the maintenance of an identity over time and what needs to be done in practice if somebody is no longer living or wanting in this moment to maintain the identity that they had wanted to maintain at one point in time. Then there is the need to really, take a step back and analyze always before intervening and reframing any inappropriate behaviors with kindness. It's really important that these are, behaviors that are not something that's just understood as a burdensome behavior, because sometimes health and social care staff are ill-equipped to provide support. And sometimes the kinds of supports that they've been provided have been, in terms of medical intervention that restrict and control what are perceived as burdensome behaviors. So this reframing with kindness, of inappropriate behaviors with kindness, does not relate to those kinds of interventions, but something that would harm themselves or somebody else. And then in terms of palliative and end-of-life care, death obviously remains a taboo in our culture more broadly. This is not specific to LGBTQIA 2S+ communities. So this is an issue that needs to be addressed in that sense. And end-of-life services generally not adapted to support the diversity of sexual and gender identities and expressions. And the literature shows that members of these communities are less likely to engage in end-of-life planning, which means they're not experiencing the potential benefits of this type of planning. And they're maybe not accessing services at the same points as their peers. So at a later point, not having benefit also from earlier diagnosis and treatment. So these are issues to be considered in terms of palliative and end-of-life care. And then in terms of the different phases, key concerns related to different phases on the continuum of between palliative care and death. There are, again, concerns about hostile environments in residential and institutional social and healthcare settings that need to be addressed. In terms of home care, there are also concerns about somebody entering your home, and learning what you don't necessarily want to be sharing with them. And there's desire for care provision tied to respect and support for one's identity. And, the fear of depending on others, which again is not specific to older adults who are part of sexually and gender diverse communities, but is part of the fears that need to be addressed, the concerns that need to be addressed here. In terms of end-of-life planning, there's inadequate accompaniment, there's not enough resources, and the resources that are available really need to be more adequately identified and communicated to the people who need them. In terms of end of life itself, social isolation can sometimes become more acute at this period in time. So there is need for support to connect with one's social networks, and particularly with one's loved ones during this period. There also needs to be recognition and involvement of chosen family and support for desire of authenticity of self during this period, and then potential spiritual accompaniment as well. And then after passing, some concerns are the misgendering older gender non-conforming and trans adults, or non-consensual detransitioning of persons. That really needs to be addressed. We need to make sure that this doesn't occur. And then again, legitimization and validation of the bereavement of loved ones remains a concern. Their grief must be recognized, and it needs to be adequately supported. So just to finish with the promising practices in this regard, there needs to be encouragement and support for end-of-life planning for sexually and gender diverse older adults. There needs to be a documentation of their wishes and a follow-up upon those wishes. Fears that are experienced need to be addressed with kindness and non-judgment. There needs to be an evaluation and evaluating particularly of the role of loved ones, of chosen family. And then spiritual care should be proposed. Spiritual care that is inclusive of sexual and gender diversity should be proposed if this is something that looks like it would be of interest to the older adult. And just with regards to spiritual care a little bit more further, it's really important to recognize that some of these older adults will have strong affiliations with religions, even though those religions don't necessarily support sexual or gender diversity. And so inclusive spiritual supports for those individuals are crucial so that they can be at peace with the end of their lives. And American research suggests that African American and Native American LGBTQ plus older adults have a higher likelihood of attending religious and spiritual activities. So there's an indication there that there might be a greater need for support for spiritual care among members of those communities. So just to end, obviously we need safe and inclusive health and social care. And as I mentioned earlier, there's some political will. I referred to the political will in Quebec. There is obviously, this is a nationally focused event. So we're not only thinking about it at that level, but I was referring to some of the will here, so that can be built upon. And in terms of dementia care, some of what is needed is support for sexual and affective needs, the inclusion of loved ones, and clarifying and respecting wishes in terms of sexual and gender identity, and supporting that. And then in terms of palliative and end-of-life care, understanding and documenting a person's needs and wishes, both during care and after passing, ensuring their continued social connection, and again, supporting and valuing their loved ones. And then obviously other forms of care need to be addressed. They weren't taken up in this presentation and in the work that we've done in CREGÉS in this regard, but the literature demonstrates that there are care needs, particularly for those who are living with HIV, and for older adults who belong to the 2SLGBTQIA plus communities who are also racialized, or who that need to be incorporated into the approaches to providing proper care. So I'm sure you have more ideas to add, and I'm looking forward to hearing about them. And once again, I'm grateful for this opportunity to contribute to this event. So thank you.